Welcome everybody to today's program. We have Atrium Healthcare that's going to be putting a program together on stroke prevention and some of the signs. Ronda Vani is going to be our presenter today. I'm Bill Russell, President of the Chamber of Commerce, and we welcome everyone. And I'm going to be advancing the slides for Ronda, but she's going to go ahead and take over the program. So Ronda, it's your show.
Thank you. I want to appreciate and thank everyone for allowing me the opportunity to spread some information on stroke today. And being that May is Stroke Awareness Week, or month, I wanted to reach out to the community to discuss things and get some information about stroke out there. It's very basic, and that is deliberate because I have a lot of walks of life in the community. So I just want to get the major information out that everyone can possibly use in their daily life. Next slide.
Okay. Are we seeing the next slide?
It is now, yeah, go to the second slide. There, yes, I have no conflict of interest, just to let everyone know before I start this. Next slide, please. And then this is the agenda. We're going to talk a little bit about what stroke facts are, so you can relate to how prevalent stroke is and why it's so important to know some information about stroke. How the brain is affected, what is a stroke, what are the types of stroke, what are some of the acute treatments that we do with stroke, and what are some stroke prevention tips. There is some subacute treatment and recovery, and then a summary. I am hoping to show a couple videos throughout this presentation, and I hope that it will work. I pray. So more to come. So next slide, please. And the stroke facts. Next slide, please. This is just the United States showing stroke mortality. And as you can see, the darker purple is where the highest rates of stroke occurs, and that's called the stroke belt. And we are in that belt. So it's just showing that we do have mortality with stroke. And that is why it's so important to have this presentation and for people to understand about stroke. Next slide, please. And this just shows the hospitalizations of stroke. So, you know, not only do people have strokes, they do get hospitalized, and some people do recover and like they never had a stroke. And then unfortunately, depending on how severe or where the stroke occurs, will depending how, you know, if they're hospitalized for longer periods of time and have a lot of effects from the stroke. Next slide, please. So some facts about stroke. Stroke is the 5th leading cause of death and the cause of serious long-term disability. Every 4 minutes, someone dies from stroke, which is unbelievable. 87% of strokes are ischemic. That's the most common stroke. And we're going to talk about what an ischemic stroke is. And $46 billion are stroke-related costs in the United States, and that's from 2014 to 2015. And the cost includes healthcare services, medicines to treat stroke, missed days of work. And then stroke increases with age, but can occur at any age. So, you know, that's why it's important for your kids and grandkids to understand about stroke. They might be able to help grandma, you know, if she has some symptoms, that they could call 911 for them. So all walks of life should be educated on stroke and know what to look for. Risk of having a first stroke is nearly twice as high for the Black Americans as for the whites. Also, the Hispanic population has seen an increase in deaths since the 2013. So they're on the rise of that too. Next slide, please. So how is your brain affected? Next slide. As you can see, we have 6 areas of the brain. It's the frontal lobe, the temporal lobe, the parietal lobe, occipital lobe, cerebellum, and the brainstem. And as you can see, all these different areas kind of control different parts and different things of your brain. So the frontal is mainly your motor activity. It's your behavior, it's your personality, it's your mood. But believe it or not, it has bladder control. So people that have strokes can have a lot of bladder issues if they have a stroke in that area. The temporal lobe is mainly your hearing and your memory. So when you hear temporal, kind of remember hearing. Parietal lobe is like perception. It's your reading, it's your writing, it's your math, that kind of thing. Occipital lobe is vision. It says, it also has dreams and your perception, but when someone talks about occipital, the first thing that comes to their mind is your vision. Cerebellum is, your posture, your coordination, your balance, and it looks like someone that had maybe too much to drink and they're trying to walk. That's how it feels when you have a cerebellum stroke. So it does affect your balance. And the last part of the brain is your brainstem. That is your major function of life. If you have a big brainstem stroke, that's not good. I mean, you could die from that. But, a lot of people do have brainstem strokes that don't have big strokes and they seem to recover okay. But it's your life functions, it's your breathing, it's your heart rate, that kind of thing. Next slide, please. So this is your right versus your left and how it impacts your life. So the left side of your brain is your reading, is your talking, reasoning. It controls the right side of your brain, which the right side is kind of the opposite. It controls the left side of your brain. And it organizes information. It has face recognition. So if someone comes up to you and says hello, you will recognize them and know who they are. It's your emotions. It's your music and art awareness. So it's more the creative side. So when your left side of your brain gets injured, you have changes in speech. You can have difficulty understanding spoken words or something written. And then sequencing difficulties, knowing 1, 2, 3 go together and ABC go together. Now, when you have injury to your right side, it's more memory issues, and you lose like the big picture when you think, you can't look at that big picture. You're just focused on that one thing. And then impairment to attention. You can't really pay attention to what's going on. So your brain has a lot to do, of course, with how you are, your mood, your memory, and how you function. Next slide, please. So what is a stroke? Next slide. A stroke they call a brain attack. And I tell my patients that it's like a heart attack in your brain. There's like a clot that breaks off from plaque or someplace in your heart, and it goes to your brain and it gets stuck. And when that clot gets stuck in your brain, you can't get oxygen past that area. And when you don't have oxygen, your brain starts to die because of lack of oxygen. And then it depends on the blood supply. Your brains start to die, they get damaged. And hopefully if you can recognize your stroke quickly, call 911, you can help this not be so huge in your life. People do recover from strokes. So just remember ischemic, which we're going to get to in a few minutes, is the major part of stroke, and that is the ones that occur most often, and those are the clot ones. So next slide, please. So like I said, ischemic strokes are 87% of the strokes, and that's where the clot gets, and you can see the picture on the right-hand side, a clot breaks off and it blocks that oxygen and brain and blood flow. So by calling 911, you can improve your survival and recovery. So next slide. Another type of stroke is hemorrhagic stroke. That is where you bleed in the brain or between the brain and the skull. And that's about 20% of the strokes. Number one cause of hemorrhagic strokes are high blood pressure or using cocaine or drugs, because it raises your blood pressure so high that it just bursts the vessel. Also from aneurysms, if you have an aneurysm in your brain and maybe your blood pressure goes up, it can burst that aneurysm. So prevention is to control that blood pressure and not use drugs. Symptoms is the worst headache of your life. That was what people say. This headache is just so bad I can't stand it. It can cause vomiting, seizures, decreased level of consciousness, neck stiffness. And those sometimes are signs of symptoms of meningitis too. So it's kind of hard to know what it is. But when you have any of those signs, you want to call 911 and let them figure it out and help you, get better. So if someone does have a hemorrhagic stroke, sometimes they have to go in and cut the skull, which is called a craniotomy, and take the skull out to allow the brain to swell. And the skull will keep that swelling from occurring. So that's why they have to take that skull off, so allow people to get better. Sometimes they just have to drill a hole, which I call a burr hole, to decompress that brain tissue. So there are a lot of ways that they can help decrease swelling and decrease problems with hemorrhagic stroke. But it is a hard thing to treat sometimes, depending on how big the stroke is. Next slide, please. So TIA is another type of stroke. They call them mini strokes. What happens with the TIA is that clot that I talked about still gets stuck in that vessel, but for some reason, it kind of breaks up and moves on, and it's not there long enough to cause any kind of damage. But a lot of people that have TIAs, they kind of ignore it. Oh, I don't know what that dizziness was, but it's gone now and I'm good. But that's probably the worst thing you could do. Anytime you have any kind of stroke symptoms, you always should go to the hospital and get checked out, because people are highest risk within 90 days of having a stroke after a TIA. 17% can have a stroke after a TIA. And if you just ignore it, you don't know what's going on and you'll have that stroke later. So, it's important to make sure that you follow up and just don't let yourself be, you can always talk yourself out of things, and we're very good at that. Oh, let me just go lay down for a little while. I'll feel better. If that's a stroke, that's the worst thing you could be doing, because every second you have brain cells dying. So don't let yourself talk yourself. Go get help and make sure that you're doing the right thing so you don't have problems with stroke later. Next slide, please. Cryptogenic stroke is another type of stroke. And unfortunately, 1 in 4 ischemic strokes are cryptogenic strokes. And what they mean by that is that they do all the testing. They do echocardiograms, they do the MRI, they do blood work, they do EKG, they do, you name it. They do blood, all this like, what do you call it? Anticoagulation, all this different kind of blood work, and nothing really comes out that's really high or abnormal or that we could say is the cause of your stroke. And that's probably the worst thing for patients, because they're very frustrated, because a lot of people want to know, okay, what happened to me? So now how can I fix it so it doesn't happen to me again? And if you don't have that middle piece of how I can fix it, then that's very discouraging. So, you don't really know what to do next. So unfortunately, we do have those types of stroke, and that's called cryptogenic stroke. Next slide, please. Next, yeah, thank you. So if you're having an ischemic stroke, we can offer patients called TPA or alteplase. That is a clot busting medicine that will go to that clot and break it up and keep people from having huge strokes. We can give it to strokes. They give it to heart attacks. You can have an pulmonary emboli, where a clot will go to your lung, and people usually have chest pain and shortness of breath. And if it's very big, they can go to radiology interventional suite, and they can kind of drip that TPA on that clot. And then if a central venous catheter is blocked, we can also use TPA for that. So TPA can be used for a lot of different things, but it just depends on the amount or the doses that you give, depending on what the problem you're trying to solve. Usually with stroke, we can offer this up to 3 to 4.5 hours of last known normal time. So that, let's say you started having some dizziness and some stroke symptoms around 9 a.m. So you need to recognize that you're having that stroke. Someone needs to call 911. You have to let the medics get to your house. They have to do their assessment. Then they have to say, oh yeah, you might be having a stroke. We need to get you to the hospital. So then they have to get you to the hospital, and then the doctors have to see you and they have to say, yeah, I think you might be having a stroke, but we've got to get this CAT scan first and get this done and that done. So if you think about it, 3 to 4.5 hours is really not that long that you can, have this drug to help you. So that's why I urge, if you don't hear one thing from this talk, please hear this. The sooner you recognize and the sooner you call 911, the better chance you have of not having a huge debilitating stroke. Some of the other problems getting this all to place is not only the time factor, is the expense. And if you have insurance, they usually pay for it and it's not a problem. But it can be up to like $10,000 for one bottle of this medicine. And some of the side effects can be bleeding or allergic reaction. People have angioedema where they have swell and they can have shortness of breath and they can have problems from that. They can bleed into their brain. But the doctors review all their risk factors, review if you've had any kind of recent bleeding, what kind of medication you're on, your past history, and they look at the risk versus the benefit. And if they feel like the benefit is going to outweigh your risks, then they will offer that medicine, but you have the last say, or your family member if you're not able to say, if you want them to have this medicine. But usually, for the most part, I don't know the percentage, but I would say 95 or higher percent usually don't have any problems getting this medicine. So there is help, but you just have to make sure you get there in time. Next slide, please. Another treatment that's offered is called a thrombectomy. That used to be offered within 6 hours of last known normal, but now with a lot of research and studies, you can give this treatment if you're eligible up to 24 hours. So what this means is sometimes it's called a large vessel occlusion. That means you have a big clot that's occluding a lot of your brain, and if they don't remove that clot, sometimes you're not going to recover and you're going to have a bad outcome. So depending on where that clot is, if it's very distal and very small vessels, they can't really help you with that. But if it's in a bigger vessel and they can get to it, they can actually go in with a stent retriever. And that's what the picture's showing. It's this retriever that goes in and it goes through the clot, and this mesh wire kind of wraps around the clot, and then they bring that out of the vessel. So that's something else they can offer is a thrombectomy. But you have to have what they call an LVO, large vessel occlusion. And if people have large vessel occlusions, you're going to know it. They have really, really huge symptoms that are very indicative of a stroke. So most people can, tell if you're having that stroke. So, and a lot of times they get that Activase or Alteplase and TPA along with this treatment. So sometimes they get both. So the reason I put this in here is that, there is help, but you just have to get to the hospital in time. Next slide, please. Stroke prevention. So stroke can be preventable. It depends on your risk factors. It depends on your family history, but there is things you can do, and then there's things you can't do. And if you'll go to the next slide, we'll kind of review some of those. So risk factors that you can't change. You can't change your age. You can't change that you're older or younger. Usually 1 out of 5 people who have a stroke are under 55, but it increases as you get older. You can't change your race, how you were born. African Americans, Hispanic, and Asian Pacific Islanders have a higher risk of stroke. And I think they think that's due to genetics and lifestyle. Gender, you can't help if you're a man or a woman when you're born. More women have strokes than men. And more women die from strokes, even more than breast cancer every year. Family history. You can't really change that. You can do some things, which we're going to talk on the next slide. But if your family member has had a stroke, then you're greater risk of having a stroke. So some risk factors that are manageable or that you can change and have a outcome, better outcome, is high blood pressure. If you have high blood pressure, you need to be checking your blood pressure at home. Don't just wait till you go to the doctor. You can, get a blood pressure machine and check it. And if it's really high and you didn't take your medicine, of course you want to go take your medicine. But, if you take your medicine and it's higher than normal and it's not going down even with rest, then, you might want to call your doctor and say, hey, I don't know, but my blood pressure's, 190 over 100, and it's not normally that high. What do you think I should do? And he might say, come see me. He might tell you to go to the hospital. Atrial fib. Atrial fib is the irregular heartbeat where the top chamber of the heart kind of quivers. It doesn't beat with a normal rhythm. And when that happens, sometimes it predisposes the bottom of the chamber to collect clots because that blood is stagnant. And so then your heart will say, well, I want to beat again. I want to beat normal again. And when it does, it throws those clots out and it can go to your brain. So you say, well, Rhonda, how can I help that? That's something, how am I supposed to do that? Well, how you can do that is by taking your medicine like you're supposed to, your Coumadin or Eliquis or whatever they prescribe for that irregular heartbeat. Make sure you go to your doctors and make sure your checkup is, you're doing what you need to do. High cholesterol is another risk factor. We look at LDL. There's tons of ways to look at cholesterol. You can look at total cholesterol, HDL, LDL, triglycerides. But for stroke, we look at the LDL. Now, if someone didn't have a stroke, we would be happy around 100. But if someone has a stroke, they would like to get that cholesterol or LDL down to 70 or less. So most people will go home, and I'm probably getting ahead of my slides, but we'll go home on some medicines for that. And we'll talk about that in a few minutes. Smoking. Smoking is a risk factor, not only for stroke. And a lot of these things are not only for stroke, but they're for heart attacks and for other heart problems and circulation problems. So if someone smokes, you want to try and not smoke. And it's not easy. I can guarantee you that. But it can be done if you really want to do that. Diabetes. Diabetes is a big risk factor for stroke and heart attacks. You want to make sure you're checking your blood sugar, you're taking your medicine, you're taking your insulin if it's needed. You're trying to eat the diabetes, appropriate diet. That kind of thing. You want to increase your activity. You don't want to be, a couch potato watching TV all day. You want to be up, you want to walk, you want to get some exercise. And if you're overweight, you want to try and lose weight. And that will help things too. Next slide. So stroke prevention, as I'm saying, is, just trying to improve and make healthier choices and healthier lifestyle choices. Instead of eating, that Hardee's or McDonald's, eat a piece of chicken and some fresh vegetables. If you drink alcohol, try not to drink a lot, try to maybe 1 drink instead of 5 drinks. And then if you're overweight, try and be more active and to lose some weight. Next slide. So number one cause of stroke is high blood pressure. So like I said before, take your blood pressure, know what it is, and communicate that. Write it down. Whenever I educate my patients at the hospital, if you want to go to the next slide, I give them this folder, and it has what an ischemic stroke is and what is a TIA. And on the left-hand side, it has the BFAST, which we're going to go over next. And it has a magnet of BFAST that they can put on the refrigerator to help them remember those warning signs. And it has all kinds of information about risk factors, blood pressure, cholesterol, how to eat, how to take your blood pressure. It has I have a graph in there that they can use to write down their blood pressure. So when they do go to the doctor, they can say, okay, my blood pressures have been doing this. Is that okay? Is that good for you? You know, should I do better? And then I have my information inside too, that, you know, they can call me if they go home and they have a question, or they forgot about something, or they just wanted some reassurance, or they couldn't get an appointment with the neurologist. You know, they can call me and I'll help facilitate that for them and help clarify some things. Next slide, please. So what I talk about mainly is, what are the warning signs? How do you know you're having a stroke? We used to go by FAST, but now we go by BFAST. And the reason we added the B and the E is because we were missing what they call posterior circulation strokes. That means the back of the head. So we added a couple other words. So the BFAST is an acronym that helps you remember those words that are some signs and symptoms of stroke. So B, if you want to go to the next one, next slide, B is for balance. So you're unstable when you're walking, you feel like you're drunk and you can't keep your balance, or you want to fall, or you're lightheaded, or you're dizzy, or you're wobbling, that kind of thing, kind of motion sickness. That's the type of balance that you'll have. Next slide, please. E in BFAST is your eyes. Sometimes you'll have blurred vision, or trouble, can't see too right. Sometimes it's one eye, sometimes it's both eyes. You want to squint and rub your eyes to see, well, why isn't this getting better? That's the kind of blurred vision. F is for face. One side of your face can droop. It's called a facial droop. And it just doesn't look right. It's not normal. Then you definitely, that's another sign that you would want to call. Some people have headaches too, depending on where that stroke's occurring. Next slide. A is for arm. Sometimes your arm becomes weak or numb or tingling, or, you know, and some people might have carpal tunnel, you know, and they normally have that. So you kind of know what your normal is, but if it gets worse or doesn't go away like your carpal tunnel does, you know, sometimes a carpal tunnel, you can shake your hand and it goes away. Well, this won't go away. This is, and then some people ask me, well, I've already had a stroke and I already have some weakness on that side. How do I know I'm having another? And I'm like, well, that's very hard, but usually it would either get worse or maybe the other side will start getting numb or weak. So that's kind of how you distinguish things. Know your body, know your normal versus your abnormal, so you know when to do something about it. And then speech in the S in BFAST is people have slurred speech, or maybe they have what they call aphasia, where they can't talk at all, or maybe they don't understand what's being said to them. So there's a lot of different ways that this person can be having problems with speech. Next slide, please. And T is time. Time, you want to call 911 ASAP. The second you notice something different or something's not right, don't talk yourself out of it, call 911. And now the next slide, I'm going to hopefully just show you a little bit about the BFAST if we can get it to play. So bear with us. All right. The next slide, I'm going to talk about some subacute treatment, like what do you do when you go home, that type of thing. So you know what to expect when you're leaving that hospital. Most people that have a stroke or even a TIA, depends on the doctor, you're going to go home on aspirin. And usually it's a baby aspirin. Now, if you've had a stroke and you're already taking aspirin, they might increase it to 325 milligrams by aspirin. But you will most likely go on that unless you have an allergic reaction or whatever to aspirin. Another medicine they use commonly is Plavix. Both of these are antiplatelets, where they don't allow the clots, the blood to stick together, and it doesn't allow the how do you explain it? The platelets just don't stick together, so the blood's just a little thinner. So when you have thinner blood, it's easier to move through your body, and you're less likely to have a stroke or TIA. So you would go home on one of those. Now, if you were on aspirin sometimes and you had another stroke, sometimes they'll even add Plavix, and you'll have aspirin and Plavix. And usually you'll do that from 6 weeks to 3 months, and then they'll stop one of them and you'll have just one of them. Anticoagulants like Coumadin, Eliquis, Xarelto, those are usually for atrial fib, and if they had a stroke that maybe from your heart that we talked about, you would be on an anticoagulant. And then statins. If your LDL is 100 or greater, you most likely will go home on a statin. What we use in the hospital is atorvastatin or Lipitor, and that seems to be the one that we use a lot. But if you're on simvastatin or Crestor or another type of statin, sometimes they will let you resume that one. But if you're not on one, you most likely, I would say 90% of the time, go home on Lipitor or atorvastatin, and that's to help reduce those the cholesterol in your vessels, so you don't build up that plaque and have a clot, break off. Next slide. Another thing, they'll want you to see your primary care, and they'll want you to have a neurologist after your stroke, because then if you see them, they can help manage your care and make sure you're getting the right tests and everything that maybe needs to be followed up on from the hospital. They can continue that quest and keep you from having another stroke and getting you in the right direction of getting better. So what do you expect besides what we already talked about is when you see a neurologist, ask them about the location of your stroke. Let them, hey, I want to see the MRI. Show me where in my brain it was, so you understand where it is and what they're talking about, and ask them questions. But don't compare yourself to other people, because everyone recovers at a different rate in a different way. So all you have to do is concentrate on yourself, and hopefully things will continue to get better. And I wanted to talk a little bit about neuroplasticity. I don't know if anyone has heard about that. But neuroplasticity helps your brain kind of rewire itself to where you can get better after a stroke, and you can move that arm and leg later with physical therapy. It happens by using the same thing over and over and over and over by repetition. It trains your brain to do certain things. Your brain can be lazy. I'm not going to lie. If you don't make your brain do something when you want it to do, it's not going to do. So when you say, no, you're going to do this, and you keep doing it and you keep doing it, then eventually it's going to say, okay, I guess we're going to do it. And it'll make new neurons, new pathways to where that makes it where you can do it. During the first 3 months, you have your most improvement, I guess your fastest improvement, but it doesn't mean that later down the road after 3 months that you can't continue to get better. So if you go to the next slide, if we can play another video, it talks a little bit about neuroplasticity and how that helps, because that's really the key to not only stroke, but other things that you can retrain your brain to do better and to be different.
Neuroplasticity. We hear the term very often these days from smartphone apps, learning centers, rehabilitation centers, and even through athletic performance. But what does the term really mean? Well, let's keep things simple. If you break down the term neuro, means nervous system, which consists of the brain, spinal cord, and all the nerves that send and receive information to and from the brain. And plasticity, which comes from the Greek word plastos, meaning moldable. So together, neuroplasticity means a moldable brain. Originally introduced by an Italian psychiatrist by the name of Ernesto Lugaro in 1906, the term neuroplasticity was a way to describe how the brain can change throughout life to adapt, learn, and even recover from brain injury. But this wasn't the first time that the concept of neuroplasticity was described. You may be familiar with the famous experiment in 1904 conducted by a Russian psychologist, Ivan Pavlov. Professor Pavlov was able to essentially rewire the brains of his dogs to salivate at the ringing of a bell. He did this by repetitively ringing a bell every single time their food was presented to them. You probably have personal experience with neuroplasticity and don't even know it. As a matter of fact, every time we learn something new, we are harnessing the power of neuronal plasticity. You may remember when you were back in grade school, your teacher told you at the end of the week you're going to have a quiz on all 50 capitals of the United States. At the time, you probably could recall 2, maybe 3 of the capitals of the United States, but how are you going to learn all 50? The chances are you probably went home and sat down with your parents and created a deck of flashcards with the state on one side and the capital of the state on the opposite side. You probably looked at the state and then read the capital. You did this over and over and over again until you're able to call the capital as soon as you saw the name of the state. So what do you and Pavlov's dogs have in common? Each of you have both experienced the benefits of neuroplasticity. You are both exposed to a stimulus accurately with enough repetition and intensity to rewire brain function. So essentially, neuroplasticity can be considered as learning. And what's the expression? An old dog can always learn new tricks. Neuroplasticity takes place every single day of our life, regardless of our age or health. As long as you're alive, your brain will make new connections, and you can increase its performance and health. Neuroplasticity doesn't just apply to cognitive skills, it also applies to physical skills. Don't believe us? Do you remember the first time you tried to ride a bicycle? You may have attempted to ride a bike with training wheels. Then once you've practiced enough, you may have removed the training wheels and then were able to ride the bike. The process of learning to ride a bike is a physical process, and just like learning information, it requires repetition and intensity. While you may have already been familiar with the applications of neuroplasticity, often people are not familiar with the new applications of neuroplasticity in healthcare. Plasticity Brain Centers is one of the leading providers of neurorehabilitation in the world, embracing a receptor-based model of neurological rehabilitation. By performing a comprehensive neurological assessment, they're able to identify either injured or simply inefficient networks in your brain. Then, by introducing specific sensory information with repetition and intensity over a 5-day program, they've been able to increase function, increase efficiency, and literally rewire the brains of children, seniors, people with neurological injuries, and even high-performance athletes. So if you want more information, give us a call at Plasticity Brain Centers to find out how we can unleash your brain's potential.
All right. Well, that I thought was a good kind of summary of what I was trying to explain about neuroplasticity. So the last thing we want to talk about is the treatment and recovery. I think that's slide 41.
Okay, hold on.
There we go. All right. So when you are discharged from the hospital, not only what we were talked about before, we can offer physical therapy, speech therapy, which also helps with cognition, not only just speaking, occupational therapy, mobility training. Next slide, please. And how we do that is by speech therapy, physical therapy, and occupational therapy. And occupational is different from physical. Occupational helps with fine motor activities, how you eat, dress, drink. And physical therapy helps just, your coordination, your walking, that kind of thing. And then speech helps you understand speech, hopefully, and interpret it and say what you want to say from your interpretation, and also cognition, helping you remember things. Next slide. And there are certain places that you would go for that, depending on how severe the stroke is and what's really going else, what other your comorbidities might have. So your rehab starts in the hospital. You'll see these physical therapies while you're there. And if you're able and your stroke is, you're still needing a lot of help, you could go to an inpatient rehab. Requirements for an inpatient rehab, you have to participate at least 3 hours of physical therapy 5 days a week. And that usually stay there for about 2 to 3 weeks. But if you're not able to do that much rehab, then most likely you would go to a subacute or skilled nursing facility to where you would just get daily rehab, and you also have nursing on site if you need it. There's also a long-term acute care facility. We call that a LTAC. And a lot of people would go there if they have multiple problems, not just the stroke. Maybe they have other problems, they were on a ventilator and they just can't, or got so debilitated from all that, and they have chronic other issues. Then you would go there to recoup. And then from there, you might go to a subacute from there. Some people would go to a nursing home. Usually that doesn't require skilled nursing. It is just because you can't live alone. Another type is outpatient clinic. You would leave this hospital, go home, and you would go to outpatient, usually once or twice a week, and you would get therapy depending on what you need, and you would have that as long as you need it for. And then the last thing is home health, to where you would leave the hospital, go home, and the therapies would come to you and come to your house. And you wouldn't leave the house normally unless you go to the doctor's appointment or something for your health. And they usually come once or twice a week, and they'll come as long as you need it, usually a few weeks. And then a lot of times people have strokes and they don't have any problems, they don't have any kind of deficits, and they'll just go home and have nothing, no rehab or anything like that. Next slide, please. So why don't we just, well, no, go ahead. We're kind of running out of time. I was going to skip that one if you want, or we can play it. It's about 3 minutes.
Let's see if it comes up.
Okay.
Let's skip that one. It's taking
Okay.
so long to load.
That's fine. It would just kind of went over kind of rehab options, and that's fine. So in summary, next slide, please. You want to know your risk factors. So you know what you can work on and what you can improve to keep you from having that stroke. And unfortunately, some people do everything perfect and they still have a stroke. Athletes are like in the best health as they can be, and they still have a stroke or have a heart attack. So those are unfortunate cases, but for the majority, people can do things to help reduce their risk. You want to know your blood pressure. You want to monitor it. You want to write it down. You want to communicate that with your doctor. You want to see your doctor at least yearly, and you want to stay on a healthy pathway for your life. You want to know what the warning signs are. What are they, and what can I do to help remember them? And if you need to write them down and have them in your wallet or whatever, you can do that. And the last thing is call 911 as soon as possible. Don't talk yourself out of it. So that is my talk. But the last thing, this video, if you could get to go, it kind of just is a good overview of the whole presentation, and I thought it was a good thing. It's about 4 minutes. If you could get that one to work, that would be great. But this video refers to the fast. They're not referring to the be fast, but it still gets the point across.
hard time moving her right arm. We think she's having a stroke.
Thanks to a class Rosie had taken, she knew that sudden weakness and numbness in her arm are signs of a stroke. During evaluation, paramedics may ask if you are experiencing any other common stroke symptoms. Because Rosie is a female and over 55 years old, she is at a higher risk for stroke in general, and as a result has taken steps to manage her modifiable risk factors, which are diabetes and high blood pressure. Now that Rosie is in the emergency room, the stroke care team will go over her medications and medical history, identify the last time she was completely normal, review the assessment by EMS, and perform a head-to-toe assessment, including a focused neurologic exam. Additional tests will be ordered to confirm how best to proceed. Common tests include blood work and a CT scan, which is what Rosie's doctor has ordered. The two main types of stroke are ischemic and hemorrhagic. Ischemic strokes are the most common and are the result of a blood clot or plaque blocking blood flow to an area of the brain. Hemorrhagic strokes occur when blood leaks into the brain tissue or around the brain.
Rosie, it looks like you're having an ischemic stroke, but because you recognized the symptoms, called 911 and got here so quickly, we're able to use a clot busting medicine called TPA to try to break that blood clot up and restore blood flow to your brain. Like any medicine we use, there are risks, and the biggest risk is bleeding. But given your history, the kind of stroke you're having, and how quickly you got here, I think you're a very good candidate for the medication. Are you okay with us going ahead and giving you that medicine to try to stop this stroke?
Yes.
There are also other methods available for the treatment of ischemic strokes, such as mechanical thrombectomy, which can be used to remove the clot. If Rosie had a hemorrhagic stroke, medication to lower her blood pressure or surgery may be treatment options.
Following her initial treatment, Rosie will be closely monitored for at least the next 24 hours in the hospital. Her medical team will begin to evaluate the reasons why she had a stroke and make recommendations for needed follow-up care. Most stroke survivors will follow up with their primary care provider and a neurologist after a stroke. Many will need some therapy to aid in the recovery process. With help of common therapies, including physical therapy, occupational therapy, and speech-language therapy, improvements can still happen even 2 years after a stroke.
It is important to keep in mind that even with quick action and excellent medical care, stroke can be a life-threatening medical event. Knowing the signs and symptoms of stroke, calling 911, and telling the operator that you suspect a stroke can all make a considerable impact on your outcome, because when it comes to stroke, every second counts. To easily remember how to spot a stroke, remember FAST. F is for face. Does one side of the face droop? A is for arms. Does one arm drift downward? S is for speech. Is their speech slurred or strange? And T is for time. If you observe any of these signs, it is time to call 911 immediately. Remember, stroke is an emergency. Be sure to educate yourself about stroke now and know that you can take steps to manage your stroke risk. Making lifestyle changes such as healthier eating habits, increasing your physical activity, and quitting use of tobacco can all make a big difference. If you have medical risk factors, taking all your medications as prescribed by your provider and going for regular checkups are key to reducing your risk for a stroke. Be sure to take steps to reduce your risk for stroke today.
All right. Well, that is what I wanted to talk about today. And once Bill is able, he can open up everyone's mics. And if you have any questions, I'll be glad to answer them.
Any questions of any for Ronda?
I thought it was an excellent presentation. My mom actually had a hemorrhagic stroke years ago and survived 6.5 years after that, but I always like to educate myself.
Yes, yes.
Yeah, definitely. So thank you for the presentation today.
Oh, you're welcome. And I appreciate your attendance.
Yeah, thank you very much. That was a really good presentation. It was very helpful.
Thank you.
Mhm.
Thank you.
I thought the B part in front of it, I knew the FAST acronym, but I didn't know that the B part had been added to it. So that was really, really very good to be aware of that as well.
Yes, the American Stroke Association, Genetech, I think they're finally adding the BE because we're finding that occurring a little bit more often than it used to, and we don't want to miss those types of strokes. So yes, and I have magnets and that I give out, and they take it home and they can put it on their refrigerator. So it's a great thing that people can think of these things to make it easy for people to remember things.
Well, I want to thank everybody for bearing with us. When you're loading videos and playing them on a
Yes.
it is very challenging. If we were able to do this in the chamber conference room, it probably would have been easier to load. But I want to thank everybody for bearing with us on the program.
Yes, me too.
I do have one last question though. If
Yes.
you're by yourself, like I live by myself, are you able to, does your brain, like if you try and do the thing with your arms or your speech, does your brain trick you into thinking that you're doing it correctly if you're trying to evaluate yourself if you're alone?
That's a good question. And it depends on where you have your stroke and how big your stroke is. But usually you're able to recognize, but not all the time, don't get me wrong. But usually you'll know something's not right and you know to call.
Okay. I always wondered if you tried to do the arm or talk, if your brain would make you think you're talking correctly and your arms are at the same level. So.
It won't make you think that, but you might try. And I don't know if it's a good thing. I don't know if it's your brain telling you, but I think we kind of like take over and say, oh, I'm going to be okay. Let me just go sit down. But yeah, but don't let that happen. I'd rather you be a false alarm than have the stroke and not do something about it.
Okay. All right. That makes sense. Thank you.
You're welcome.
And then Bill, this is Kiwanda. I have a question for Ronda too. I want to thank her first for doing this, for educating us. And then I just wanted her, there's a lot of letters behind her name. And I just wanted you to just tell us, more about it and your history.
Oh, okay. Well, I have been a nurse for, I don't know, probably 35, 36 years. 30 of those years, I've been an ICU nurse. And then as a late bloomer in my 50s, I got my master's in executive leadership, and I took on the stroke coordinator role. And then I want to say October of 19, right before the pandemic, I took the position as nurse manager of administrative services. So I still have stroke, but I also have diabetes and wound care, dialysis, palliative care, spiritual care, teleneurology, ACLS, BLS, and stroke. So I have all that now to manage. I like being busy, so I guess it's a good thing for me. And my MSN, of course, is my master's. The SCRN is a stroke certified registered nurse where you have to go and take a test. And CCRN-K is a critical care certification, which is pretty tough. I got that back a long time ago when I was in the ICU. And now that I'm not bedside, I'm more in the managerial role. They put a K for knowledge. And I just have to keep up my my hours and education to keep those. If not, I have to retake the tests. So that's what all that means.
Rhonda, we want to thank you and Atrium for putting on the program today. This was our second virtual program back to back. We had United States Senator Tom Tillis at 8:30 for a Focus Friday, and we're going to have that up later on today for view to our chamber members. I want to remind everybody that next week is Small Business Week. So we kick off the week with a program at 11 o'clock on Monday, also presented by Atrium. We have Arlene Cash, who is going to be talking about unconscious bias for a diversity program. So we have that. Wednesday, we're going to be having a reception at the chamber, recognizing our small businesses of the year in Cornelius, Davis, Huntersville, and Morrisville. And then Wednesday night and Thursday night are our signature events, 6 o'clock to 8 o'clock. We have some motivational speakers. I encourage everyone to go to the Lake Norman Chamber website, lakenormanchamber.org, for the timetable of when everything is going to be occurring. So just please go to that. And I know Sylvia's going to be sending out emails reminding everybody. But again, Rhonda, thank you, and Atrium for being outstanding partners in sharing this information today.
Thank you. I appreciate that. And I thank you so much for giving me the opportunity to do this.
Have a great day at the lake, everyone.
Bye-bye.